Welcome, everyone. Greetings. Thank you for joining us this morning. To those who are just coming inside the Zoom room, we will go ahead and start. My name is Alexa Dava. Thank you so much for joining us today. I am the Project Officer for Human Dignity and Reproductive Health at the World Council of Churches, and I am going to moderate today's webinar. Our webinar today is purposely held during the 16 days of activism against gender-based violence, and this campaign raises awareness about the ways women and girls are particularly vulnerable to violence. 1 in 3 women experience violence in their lifetime, and as Christians, this high rate is a concern for all people, not just women. So addressing reproductive health is one part of reducing violence against women. And so today we commemorate the launch of the WCC's new resource, Love, Justice, and Reproductive Health, a framework for churches. And to do this, we will discuss with faith communities who are already engaged in this work from the perspective of Christ's care. Today, we have a wonderful panel of experts in the field of faith-based work on reproductive health, and so I'm excited to hear and learn from them alongside all of you. But before we do that, I have asked Reverend Nikki Ashwood with the WCC. She is the program executive for the community, the just community of men and women, and she will open up in prayer. As she is unable to be with us in person today, we have asked her to record a prayer video. So will you all pray with me in spirit and in body, wherever you are?
Loving God, in a time when reproductive health and rights are on the calendar for everyone, we recognize that there are girls and women who face challenges, especially in the area of fistula, female castration, access to menstrual health products, and many other such issues that cause shame, a sense of being less than, and may even limit them to the margins as the myths and other issues surrounding them cause them to be subject for scorn or derision. We recognize, oh God, that these are some of the issues that separate women in communities, that create challenges for them to complete their schooling or to access equal opportunities in the workplace or in other spaces, and sometimes even in the church. But Lord, we remember that you healed the woman with the issue of blood. We remember that you raised a dead girl. We remember that you are the God who heals, who hears, and who offers hope. And so as we seek to launch this new toolkit on reproductive health, we pray, oh God, that all those who have access to it will find cause to learn, to be engaged, to be challenged, and even to find spaces of hope. May it be a point for instruction and sharing of ideas, but most of all, may your name be glorified. We pray your blessing on the rest of these proceedings as the World Council of Churches continues to offer itself to you for your glory and through your support to find an end to sexual and gender-based violence all around the world. This is our prayer in Jesus' name. Amen.
Amen. Thank you, Reverend Nikki. And now I will introduce Reverend Dr. Dr. Manoj Kurian, who is the director of the Commission of Churches on Health and Healing, and he will offer us some opening remarks before we introduce our panelists and begin our discussion.
Dear brothers and sisters, on behalf of the World Council of Churches and its health and healing work, I welcome you to this crucial webinar to debut the publication Love, Justice, and Reproductive Health, a framework for churches. Reproductive health encompasses various domains of health, including antenatal, maternal, postnatal health, menstrual health, and sexual health. According to the World Health Organization, reproductive health is the term used to describe a state of physical, mental, and social well-being in all matters related to reproductive systems at all stages of life. Obviously, it's just not the absence of disease related to reproductive health. The ecumenical movement under the leadership of WCC's Christian Medical Commission in 1989, after a 10-year study process, defined health as the dynamic state of well-being of the individual and society, of physical, mental, spiritual, economic, political, and social well-being, of being in harmony with each other, with the material environment, and with God. So the WCC's definition of health is to be understood as providing a concept of wholeness that reflects the biblical version of shalom, which is peace that incorporates salvation and healing, characterizing the establishment of the reign of God. Reproductive health is a crucial and precious aspect of all stages of our lives. It is our mandate as faith communities to strive to provide safe spaces for dialogue and discussion, dependable and evidence-based information, and the access to the quality of life, care, and services that enable each person to live fulfilling lives in dignity. So ensuring that all have access to positive reproductive health is an issue of justice, peace, integrity of creation, and spirituality. Love, Justice, and Reproductive Health, a framework for churches, offers a compassionate, biblically grounded approach to reproductive health and support. This new resource draws from the wisdom of our faith and scientific understanding, and it is aiming to equip churches and church leaders with the knowledge and sensitivity that is needed to minister effectively in this crucial area. I wish you a blessed and fruitful session when you can share your insights and learn from each other and from this new framework. And I hope that this could strengthen your ministry. Let us move forward with courage and solidarity, guided by the Holy Spirit, as we seek mutual transformation in this vital aspect of human life and flourishing. Thank you.
Thank you, Manoj. Again, Manoj is my colleague at the World Council of Churches, and he was unable to be with us in person today, but he is the director of the Commission of Churches on Health and Healing. And so before we move into discussion, we would like to hear a little bit from you, the webinar participants. We have a poll set up, and we'd like to know where you are joining us from today as the first question. So if you can just briefly tell us where in the world you are, that would be great. Many people coming from Europe and different parts of Africa. And we have some Middle East representation, Caribbean representation, also a large North American representation. Thank you so much. And now we'll move to our second question, which is what brings you here to this session? What brings you to this conversation about reproductive health and faith? Great. So many people who have worked in reproductive health, or you come from a faith community or faith organization, and this is the place to be for intersecting those two fields, or a field that merges both of them. So thank you so much for participating. Without further ado, we will get into our panelists and our discussion for today. So the webinar today will have 2 rounds of discussion, followed by some time after both of those rounds for Q&A, and we will invite participants to share their questions in the chat, and we'll have our panelists answer some of your questions. But for our first round, our panelists will discuss how they navigate challenges within reproductive health and share what their organizations do to alleviate barriers to reproductive health. And so our first speaker today who is joining us is Dr. Amon Marti, who serves as the Health Secretary for the North Central Diocese of the Evangelical Lutheran Church in Tanzania. He is also the Executive Director for the Celian Lutheran Hospital in Arusha, Tanzania. Dr. Marti, greetings. Great to see you here
Thank
today.
you. Good
Thank you for
evening.
joining us.
Thank you.
Our question for you today is, I wonder if you could share what you see as the biggest reproductive health challenges in your work and your context, and just share about what you're up to in Tanzania.
Yeah, thank you very much. As I've been working here for many years, but I've worked here as a hospital director for 8 years. And one of the services we are offering in the hospital is sexual and reproductive health. And we have father, mother, and child clinic where we offer these services. And the biggest challenge which initially we faced is how to give the correct, to give the proper sexual and reproductive health to women and girls with disability. This was a very big challenge to us, and later we came with a project which now is supporting women and girls with disability. And one of the things they are benefiting is to get education and on sexual and the reproductive health. So the challenge was the big gap, especially to our staff, and how to serve the women and girls with disability. How can we serve them and make them understand the importance of understanding their sexual and reproductive health? So in the institution, we saw that it was a very big gap, especially after the auditing which was done here on how to give a good care and sexual and reproductive health to women and girls with reproductive problems. So we in the hospital, after seeing this gap, we did the training to our staff, especially to understanding about the different disabilities, and especially when it comes to women and girls, and what is right to this group. Do they have a right to have kids? Do they have a right to have access to sexual and reproductive health? And do they have a right to attend their maybe clinics? Or if they are pregnant, what should be done to this group? So we gave our education to our staff under the project we have in the hostel on our resilience disabled project, and the opening a way for the staff to understand how to help this group which were not properly given proper education on sexual and reproductive health. But after doing that, then the gap came. Yes, we have people who are disabled. When they are coming to the hospital, how do we help them? We don't have proper toilets for them if they have physical disability. We don't have people to interpret if the disability for the people who they cannot hear. And all this, they need to get a proper education. How do we communicate with them? So through education and improving our environment, preparing a special place for privacy for them, preparing the staff who will talk with them. So this really helped us to improve the services we are giving them. And sometimes they are coming with pregnancy. How do we communicate with them when they're coming to the labor ward? That was a big challenge to us. So through all these projects, we were able to train our people, get the proper beds for delivery, and assisting them to go to the bed. These are the things we improved, and it makes us easier to help them. So the big gap with sexual and reproductive health in our community really was how to serve the disabled women and the girls, especially when it comes to sexual and reproductive health.
Thank you so much. Yes, so Dr. Amon Marti's work is on creating programs for women who, or all people who live with disabilities, which we know is not a homogenous category, but thank you for sharing on that. And again, if you have questions, we can yield them for the end. Now I will move to our next panelist, who is Miss Emily Vedrud with ACT Sweden. And Emily is a policy advisor in sexual and reproductive health and rights at ACT Church of Sweden. She supports and engages in advocacy and policy work on various issues at both national, global, and regional levels via decision makers and other relevant stakeholders. She has been engaged in global health, public health, SRHR, and faith in an international context for the last 15 years. And so we will turn to Emily to ask, as our only panelist focus on policy today, could you highlight how restrictive sexual and reproductive health policies impact individual and societal well-being, and then share about the work of ACT Church of Sweden in this area? An extension of that question is, how do these efforts reflect the church's theological commitments to a theology of embodiment or bodily autonomy, and what should churches better understand about the link between faith and SRH advocacy? Big questions.
Thank you. Pleasure to be here, and thanks for the wonderful introductions and the previous panelist as well, from ESCT, somebody I know well. So we heard a little bit about kind of what this large umbrella of reproductive health, as it says in the framework. I will maybe use the acronym SRHR, Sexual Reproductive Health and Rights, which is in line with our policies and our positions. So if I say that word, it's this large umbrella of many things that are encompassed in the framework. And maybe let's start with how these impact individual levels and societal levels. Just as an example, of course, maternal mortality and morbidity, inadequate access to SRHR services results in high rates of maternal deaths, especially in low-income regions, and so many other like individual levels where people don't have access to care, both on their lives and morbidity and mortality. There's also the societal level impact. Economic burden, I think, was also referenced earlier in terms of this is not a health issue alone, it impacts beyond that. You might not be able to have access to education or enter the labor market due to not having adequate SRHR services. And that's there might be very large strains on the health systems when there's high maternal and neonatal mortality, for instance. There's also intergenerational effects that poor SRHR outcomes impact children's health and well-being, perpetuating cycles of poverty and inequality. And this is very much a poverty issue. It's a key contribution to both creating poverty, but also can then be something that can create poverty alleviation. And even though there is more people across the world that have access to this healthcare and education, there's huge disparities. And that is due to a lack of political will and lack of implementation of existing policy frameworks on this matter and services. And here the role of faith communities is crucial, as referenced in the framework. And there's many in places where faith communities are important in relation to this, but I will mention two. One is, as says in the framework, the huge amount of social healthcare services that faith actors provide for the most marginalized often, and often without adequate support from the state to do that. And faith actors also influence the uptake, acceptability, and accessibility of services. And faith communities, and in particular faith leaders, have a deep impact on influencing norms and attitudes, both that can enable political transformation on these issues, but also that can mean how it's hampered because of the norms at the community level, but also as duty bearers at a societal level or even a regional level. Maybe a little bit about the policy space at this point. It's a lot you can say about that, but some of that is in the framework as well. It has both advancement and challenges. One that is referenced in the framework is an important one to note is the International Conference on Population and Development, set in Cairo in 1994, and marked a very pivotal change when we started as an international community looking at the issues of reproductive health as a human right, but also central to development for societies. And here also, the World Council of Churches were present and made a beautiful statement in 1994. And this framework has subsequently guided in many ways how we do policies on these matters. It also is referenced in the Sustainable Development Goals, the new coming Summit for the Future, and also other UN frameworks. And of course, that trickles down to the regional level, Maputo Protocol being one central one on the African continent, Montevideo Consensus, maybe another one in Latin America. And there's often very robust policies existing, but the political will and the implementation, sometimes the financing, is what is lacking. And here faith actors are crucial as stakeholders, and sometimes both for ensuring accessibility and also not. And alongside that, of course, is resource allocation, economic constraints, as well as maybe political or cultural barriers, and also the inequity of access for marginalized populations, particularly adolescents, rural communities, women, girls, LGBTI individuals, or even, as we heard now, how does that impact on other areas, such as if you have a disability? So it has a huge human cost and a huge societal cost. And amongst that, we also see a global pushback against a lot of SRHR or gender equality policies. And that has been going on for over a few decades. And we see that playing out both at the global space and the regional space. And that was not always the case in that way, but it's very much been intensified. And there's and that has consequences. It has consequences, of course, ultimately on the ground and the people and communities. But it also has a huge impact on how faith actors are seen in the policy space. It has led to a common conception that human rights and religion do not align, so it impacts beyond this area in particular. While we know that faith communities in the diversity respond to this issue in many different ways and to the needs of their community. And they're not only blockers, but also crucial partners to this agenda. And this leads to polarization many times, which often then mask this diversity of how faith actors are engaging in this area, and also mask the human rights violations that happens against individuals at the intersection of reproductive health and faith. For instance, that access to care can depend on citizenship, and if there's discriminatory citizenship laws in relation to religious minorities, for example, you might have lesser access to health services. So it's very important that the religious analysis and the analysis that we know as faith actors is important for the health of all. And this polarization also makes it harder to find a common ground and expand the common ground, as there is so much that faith communities agree on more than pulls them apart. And our challenge is to very much expand that common ground and work with each other to stay open in dialogue. And in these times of polarization, this is one of our most important tasks. And this is, of course, Actors Sweden working on this in its policy work, emphasizing and listening to and centering our theology around these issues. And maybe we can get back to that now because I see Alexa coming on the screen. So I'll maybe save some of these things. But something I will end on is where we, in our policy work, or however we do our work, where we start our theology from really matters. And that's very much how Actors Sweden has centered its positions on these on SRHR matters. It has to start with the position of those most affected. And how do we center those? And when we do our work and when we do our theology, as these issues are very pressing, there's a huge impact of it across the world, with the human cost ultimately being the consequences, and the women and girls ultimately bearing the consequence of that. And that many faith institutions have been insecure, or remained absent or silent, or even opposed some of this. Well, I think there's many times that has been due to many other factors that we can bridge and learn from. And the policies opposing these things are, as we said, now we're centering this on 16 days of activism, is a gender-based violence when we don't have access, when women don't and girls don't have access to these things. So it's very important that we have this conversation now. And this framework is such an important tool and start. So thank you.
Thank you, Emily. Thank you so much for covering so much and within 6 to 7 minutes. I especially want to highlight the emphasis on expanding the common ground and highlighting kind of the misconception in human rights spaces that religion is incompatible with human rights and the need to fill that gap. I am pleased to introduce our next speaker, Dan Irvine. Dan is the Global Director for the World Vision International Health and Nutrition Department, where he has served since 2007. And in this period, he has championed the adaptation of the Channels of Hope SBC model for faith actors, and I'm sure he will share what SBC stands for. And this originally developed to address HIV and AIDS and the stigma around HIV and AIDS for additional issues, including sexual and reproductive health, or SRH. And currently, Dan says that World Vision is finding rich common ground, to bring it back to common ground, with faith actors in addressing population mental health and psychosocial needs, which also interact with SRH and maternal and child health outcomes. So Dan, will you please share about World Vision's approach to influencing reproductive health outcomes, and particularly will you share more about Channels of Hope in this program at World Vision?
Thank you, Alexa. I'm very happy to share. I'd like to thank the World Council of Churches, firstly, for this invitation to share and for organizing the Love, Justice, and Reproductive Health Strategy, which we'll speak to more through the event today, and just to extend warm greetings to all of the participants who have joined today. So, on sexual and reproductive health and rights, as Emily points out, World Vision has for a very long time been addressing the subject in an integrative manner within our health and nutrition sector, as well as through other sectoral areas of our work. And I'd first perhaps start by pointing out a couple of parameters that drive our work. One, seeing this as a life cycle issue. So from a health perspective, classically, we've been working deeply into a young child and maternity health agenda, but which then very critically incorporates a need to work with mothers and families continuing to plan their family planning, working with women of reproductive age, increasingly working with adolescents, also from a number of perspectives on the sexual reproductive health question. Secondly, it's a piece of work that needs to happen at multiple levels of society. It needs to happen at the household level, within the community, and certainly at the level of service provision and policy. And in the best scenarios, we have investments and interventions simultaneously across that ecosystem of needs. As I said, we see this as a multi-sectoral initiative wherein not only health actors need to play their part, but there are strong needs within social protection, within the education system, for child protection, and from other areas of work. And to the extent that there is synergy between those actors and stakeholders with faith actors as well, we see greater success. And finally, recognizing that, like all of our development issues, we have a need for intervention on the side of demand creation for services, and we can speak about literacy, health literacy, and increasing family awareness of sexual reproductive health issues and challenges and opportunities, and how it impacts their life. Also looking at the supply side of services to make sure, for example, that an array of modern contraceptives would be available, that counseling and referral services are available, as well as other aspects of the health service. And very importantly, addressing the sociocultural issues that come in between the lines, if you will, addressing attitudes and behaviors and barriers that families face as they try to attain sexual and reproductive health and rights. So I will speak to our Channels of Hope initiative. But before I do so, just to note that in addition to that, we have many kinds of interventions addressing those different aspects of the work, from organizing social accountability within communities to help communities engage duty bearers on the provision of sexual and reproductive health services within their communities, counseling families through pregnancy, pre and post pregnancy, young childhood, adolescence, on sexual reproductive health aspects, working with mothers groups to empower them, a lot of capacity building within the health system on supply chain strengthening and strengthening workforce with midwife training for frontline health workers and emergency obstetrics, etc. So quite a large array on the health side, as well as in other areas of the work. In regards to Channels of Hope, which is a sweet spot for our discussion here, because it very much mirrors the love, justice, and reproductive health recommendations. A lot of synchronicity there. To provide a little bit of history, World Vision first began developing this approach during the peak years of the HIV/AIDS pandemic as a methodology for constructively engaging faith actors on questions of stigmatization, discrimination in the HIV and AIDS space. And the methodology developed there is a social behavior change approach, highly structured, highly qualitative, for working with faith actors to create a bridge between our best understanding of the science, in that case of the HIV/AIDS disease, and to develop a more proactive and positive appreciation of what multiple faith theologies actually support in addressing an issue like HIV/AIDS stigmatization. We, in the process, help faith actors explore their theology constructively, explore the existing science and evidence about the public health issue. We help them identify within their contexts the local barriers and myths that are prevalent and common there, and then to try to bring that all together to empower them to engage with their congregations and their communities in a positive way, building from both a science and theological platform. Following on the success of the Channels of Hope implementations in regards HIV and AIDS, we began to adapt it for other issues. And so we have successfully implemented the methodology around issues of child protection, around gender equality engagement, and very important in maternal and child health and sexual and reproductive health specifically. Along the way, we recognized that a lot of our work with faith actors in the faith sector appeared very positive, always receiving very positive feedback amongst faith actors and communities on the engagements, high energy, looks good. But we realized that we had to empirically demonstrate impact and develop a robust evidence base around the actual impact of the approach. So we began to invest that way. And a few years ago, we, for example, managed with some funding from the Bill and Melinda Gates Foundation, as well as Templeton Foundation, a couple of studies, quasi-experimental, working with 4,372 mothers of children under the age of 2 in Kenya and Ghana, looking at the implementation of Channels of Hope and our social accountability work combined. And we were able to demonstrate evidence such as a 30% greater odds of contraception use where faith leaders had been engaged. 6,000 women in Kenya referred to family planning services by 136 trained faith actors, of which 3,847 of those mothers adopted contraception methods, a 20% higher contraception use over a 3-year period of time in the intervention areas across Kenya and Ghana, and a 25% delay in first pregnancy until 18 years across the contexts as well. So really very strong evidence of impact of the faith actor specific engagement that we invested in there. And it really, for us, it's been extremely encouraging to note the opportunity and the power of working with faith actors in this space and the very concrete outcomes that can emerge from it. Now, that's very specific in terms of family planning type activities that we were looking at. We weren't looking necessarily at a broader gender equality impact stemming out of that. We can expect that there is, but I think it's reflective of the opportunity that we all have in moving forward guidance such as love, justice, and reproductive health to really impact this area of work, working with faith actors in that sector.
Thank you, Dan. Thank you. World Vision's work in this area is so comprehensive, and we could spend a whole webinar exploring that too. So I appreciate your sharing. We will now turn to our fourth and final panelist, Naekuas Tapkwek with Norwegian Church Aid. Naekuas is trained as a midwife with the Kajukeji Health Training Institute, and she will share about the links between gender-based violence and reproductive health in the South Sudanese context and how her work addresses these links. Naekuas, please take it away.
Okay. First of all, thank you so much for inviting me to participate in this webinar. I also would like to thank the World Council of Churches for getting some time to develop this toolkit that will help, especially the faith-based actors who are in the field. So thank you very much. The question is the link between gender-based violence and also the work NSAID do to mitigate. First of all, let me just highlight the context of South Sudan. So South Sudan has the highest gender-based violence and in East Africa. Actually, it is the second highest after Uganda, and also has the highest maternal mortality in the world. And when you look at it, about 53% of girls are married before they turn 18. That means they're still adolescent. And the recent half-year report on sexual reproductive health, so on GBB, information management, at least 32% experience sexual violence. Next. So you can also move to the next one before you come to the link. Yeah, so before coming to the linkage between SRH and GBB, so let me highlight the issues that are facing women and girls in South Sudan and everyone, and barrier to the facility. So first of all, as we have seen in the previous slide, the issue of maternal mortality is very high, and issue of gender-based violence is also very high. And in the context of South Sudan, there are no health care in some of the areas, no health facilities, no health personnel, even information to get information on sexual reproductive health or gender-based violence is limited in some of the areas. And this is because the structures, the political structures, where in most cases only in the urban area where there is a government structures, but when you go to the villages, they are not there. Economic crisis also become a problem. We have a lot of intercommunal violence. And then the natural resources, disasters such as the flood, then now the conflict from Sudan. So it makes it even very difficult to reach out to the most needed people. And due to cultural barrier, religious belief, it is very hard for the survivors of sexual violence or gender-based violence also to seek services. You can move now to the first slide, the one that you just skipped. No, the one you just skip the link. Yeah. So when it comes to the linkage, we all know gender-based violence is a reproductive health issue, especially the sexual violence. It is a public health issue. It's also a human rights violation. And those who experience sexual violence, they're at risk of contracting sexual transmitted diseases. They can end up with unwanted pregnancy and unsafe abortion. Why? Because in the context of South Sudan, if you conceive out of, due to maybe you have been raped, the family would not accept you. Even if you are married, the husband would say, no, I cannot take back this person. So you would end up doing unsafe abortion because the law does not allow you to access safe abortions. And this is something interrelated and also traumatic. Again, when you have been psychologically abused, you are likely to be emotionally tortured. You also lose the autonomy, that self-confidence is no longer there. So even the decision on sexual reproductive health for you become an issue. Issues of child marriage, girl child compensation in South Sudan also is an issue, because if you are married at the age of 13, 14, or at that age, you are going to engage in sexual activities, and at the results, you will end up getting pregnant or contracting diseases, which can in turn also lead to complication during childbirth and sometimes to maternal mortality. Next slide. Yeah, next slide. Next. So what do we do as NCA? So NCA has developed a toolkit called Comprehensive Sexuality Education. So this is a toolkit that focuses target adolescents from school, those who are not in school, to engage them to understand the changes that happen during the puberty time. It is about physiological changes, biological changes, how they can make decisions, how they can cope with those changes, how to prevent STI decision making, and sexual reproductive health. We also take them through menstrual hygiene. We distribute dignity kit, that is menstrual hygiene kit. We also train some of them on how to make reusable dignity kit or menstrual hygiene kit. So this is to ensure even where there are no health facilities to access those information, at least they are equipped with knowledge to make decisions on their own sexuality. Next. Yeah, you can continue. Yeah, so that CSU also does not only focus on reproductive health, we also incorporate the gender-based violence, so that when such kind of thing happens, especially post-marriage, they are able to report and seek help. We also share the referral pathway. Then the second one is family planning interventions. NC is running women and girl-friendly space. Actually, we work through implementing partners. So in the women and girl-friendly spaces, especially where there are no health facilities, we do family plannings, community conversation and dialogues at the community level with the faith-based actors. We also do it at the women and girl-friendly spaces. Then we provide contraceptive, especially those non-invasive ones, like the orals, condoms, and also the depots. But when it comes to those long-term, we refer them to certain facility that we identified and trained the health personnel. Next. Then we have the SRH in general that also focus on capacity building and also the capacity strengthening of the health facilities. South Sudan in some areas, lack even midwife. Even where there are midwife, you will find there is no health facilities. Where there is health facilities, sometimes also you will find there is no medical equipment, there is no medicine, and there is also no trained health personnel. So what we do here? First of all, we train the health workers on clinical management of rape so that when there are cases of sexual violence, cases of intimate partner violence, they are able to respond to them in a manner that is important, and also while maintaining the confidentiality, the ethical way exactly. And see, also we sponsored the training of midwife at Catholic Health Institute, Catholic universities, and also Mary Health. So they go through 3 years program. Then after they graduate, they go back to their villages. We actually bring them deep from the rural area so that they can provide maternal and child health services. We also distribute delivery kits in those health facilities where mothers could not access any of those kits, because in the village, sometimes they even use the reed to cut the cord. But in this case, this is where we distribute those delivery kits. We also distribute medical equipment, gynecological equipment, such as delivery coach and Peterscope and so many others. Where there are no trained health worker or qualified health worker, we train traditional birth attendant and those who work in those areas on how to identify like danger signs during pregnancy, importance of SRH services, so that they refer mothers as earlier, because the distance sometimes to seek services is very far. So at least they are able to identify the danger sign during pregnancy, during labor. This is also what we do. Next. Next slide. Yeah, the second one is related to gender-based violence and also include the reproductive aspect. NCA has developed a toolkit called faith-based actor motivating empowerment. So this toolkit is engaging different faith actors, Christians, Muslim, different faith community. We engage them on community conversation and dialogue on sexual reproductive health, on GBB issues, how to present them. And then they come up, after they go through series of sessions for weeks, this is when they come up with some action plan, where in their churches, either mosques at the community level, they formulate some prevention messages to recite in the church during the sermons. The second thing also that they do, sometimes they organize radio talk show, then sometimes they interface where they also meet with the community, then they dialogue on these SRH issues, on GBB issues. And this is something that we have seen also has been working. They do conduct awareness raisings at the community level, door-to-door, public awareness raisings, and also the other thing also they do is to call different actors together, and then they sit and dive on specific issues. So we also face some issues with some churches, especially Catholic Church, where in some area where they say, no, you know, you are trying to interfere with creation when you talk about sexual reproductive health, and it has been a barrier sometimes. And also in the colleges where we put the midwife, there are some college, especially those one under Catholic, where they don't want the model on family planning to be taught in school, though this is something the government approved. So this is where we bring in other influential church leaders to come and interact with them. And in the recent days and also last year, they have taken up, so they're using those messages in the church, they're advocating without fear. And we have seen a lot of changes where the community come up and form some bylaw where if something happened, they respond, where they can also punish the perpetrators, especially in areas where the police is not available. But then
Naikua,
yes,
thank you so much. I'm going to ask you if you have maybe one or two concluding thoughts.
okay,
Unfortunately,
maybe
we
you
have
can
to
just
wrap it
move
up.
to you can move to the next slide, then I just close it up there. So then
Okay,
we
thank
also
you.
do the response services. In the response services, this is where we provide the training on clinical management of rape, which I said before. We provide psychosocial support to GBV survivors within the women and girl-friendly spaces, and the training also that we made the church leaders and the other place leaders like Muslim community, they provide psychosocial support within their churches, especially where they cannot come to access services at the women and girl-friendly spaces. So maybe I can stop here because of
Thank you.
time.
Thank you so much. It's great to hear about how comprehensive the work is, and I'm sure we'll have a little bit more time for discussion at the end. Before we turn to talking about the new Love, Justice, and Reproductive Health Framework and hearing from these panelists about their thoughts on it, I will briefly introduce Gracia Ross. She is the Program Executive for HIV and AIDS, Reproductive Health, and Pandemics here at the World Council of Churches, and she will share briefly about the WCC's work historically and now on these subjects. Gracia.
Good afternoon from Geneva, everyone, and good morning, and I don't know, good evening. I don't know where you are. Thank you so much for joining the webinar for the launch of this important framework. I apologize if you hear some noise. I am in another meeting that I committed to be, and it's precisely of the interagency task team on the linkages between HIV and sexual reproductive health. And so I cannot manage to avoid the noise. I just wanted to give some brief summary of the work of the WCC on HIV. The HIV program, which now is called HIV Reproductive Health and Pandemics, has more than 20 years of experience. It started as a response to the request of the churches, principally from Africa, when the HIV epidemic was really causing a lot of death. Treatment was not available. So in the first years of the HIV program, it was dedicated so much in helping people to have a dignified death and also to reduce a lot of stigma that has come in the faith communities. Over the years, it has evolved and it has included, for example, the discussions of gender-based violence, sexual reproductive health and rights as well, and the role of men, for example, sometimes also discussions around children living with HIV, and the epidemic itself is changing. Right now, we know the HIV epidemic is still a very important pandemic in the world. We count more than 39 million people living with HIV. I am an anthropologist from Bolivia, and I am also an advocate living with HIV. And this topic is very important. And we cannot say HIV has come to a reduction. Actually, the ones that are getting HIV now are very young people. So that's why now in the HIV Reproductive Health and Pandemics program in the World Council of Churches, one of the important topics is young people and the vulnerabilities, the exposition they have for HIV and any topics in sexual reproductive health. I just want to commemorate this framework. It has taken some work to bring these ideas together, and it's very important that the faith communities are responding to this call. I'm very glad to see how many people are participating on this launch. We hope to hear from you also in the next year when we start piloting this framework in some churches, with some churches in some countries. We would like you to be there and do this with us. Help us in finding the spaces to start this work. Help us in finding the resources to sustain this work. Internationally, the funds available for HIV and sexual reproductive work is really decreasing. So it is really up to us to find the ways of sustaining this work. And why we do this? It is because the people in our faith communities, women, young people, men, they need these services. We cannot avoid the reality of sexual reproductive health needs that our young people, our women, our men in the faith communities are living. Early pregnancies at a very young age is just one example of those. Cervical cancer among women who are members of our faith communities is another example. Gender-based violence that women are exposed to when they are pregnant, when they are young mothers, is another example. So there are many areas in which the faith community has to come in a stronger way. This is our mandate. We are called to respond to the needs of the vulnerable communities and to care for our faith communities. And our call also includes not to let our people die out of ignorance. A lot of our faith communities don't receive information about sexual reproductive health. We think that maybe the schools are doing this, maybe the parents are doing this. The reality is that probably nobody is talking about this, and young people are learning using their phones. So it is our responsibility to educate young people and women in the vulnerable communities in what they need to do, and without losing our spiritual and theological approach to the topics. So I thank you so much for being here in this webinar and for your enthusiasm responding to this launch. We hope to see you in the implementation of this framework in different countries in the world. We don't know yet where. We are going to try to find spaces where to do it. It is very difficult. We are going to try to integrate this in any country that we are doing HIV work. Those could be at least 4 countries in Africa. So thank you so much for coming, and congratulations.
Thank you, Gracia. Thank you so much. Yes, it is up to the faith communities, right, to actually implement this framework. And so now we will turn to our second round of discussion. I'm looking at the time, and so I'm going to ask panelists to keep your response to about 2 to 3 minutes, and I will cut you off if it starts to go over that. But this webinar is to launch the new framework for love, justice, and reproductive health, which you will be able to find online. And we will include the link for that and everything at the beginning of this webinar. But our panelists who have reviewed the framework and have also shared about their work on this subject, I'm going to invite you all to share, what do you think is helpful about the framework? What would you change? What would you add? And I will invite whoever wants to speak to that first to go ahead.
I'll jump in, Alexa. Firstly, to say that I have a high level of appreciation of this document. I think it's been elegantly composed and written. I think its framing is excellent, and it hits most of the right notes. I particularly love the emphasis on equity, the emphasis on working from a perspective of love for our girls and women and engendering that love, for its language in regards addressing issues of fear and power, and its ambition of contributing to a growing culture of equality for women. What I would suggest thinking about in the recommendation, the framework of recommendations, is firstly to speak more proactively about comprehensive sexuality education, engagement with faith actors. There is a history of faith actors using the life skills language that this document, in fact, uses in those recommendations, and minimizing a more holistic CSE curriculum, which many governments and partners are more typically moving forward, and that becomes problematic, actually. Secondly, I don't think that the recommendations currently even mention specifically the word violence. And violence and addressing violence is paramount for faith actors in their communities to make progress. There aren't issues like early enforced marriage, for example, as well as many of the other violence issues that have been mentioned by my colleagues here. Thirdly, in the ongoing actions section, there is a recommendation to exercise care and compassion for adolescents who become pregnant. I would urge us all to promote care and compassion for adolescents before they become pregnant. If we only begin to engage them proactively when they become pregnant, we have missed our opportunity, actually. We need to exercise care and compassion for adolescents coherently, proactively, bring them in a participatory manner and walk with them in the difficult journeys that they have. Fourthly, think about life cycle considerations, because it's important that as we look at the SRH agenda, I should say SRHR, that there are issues across the life cycle, and we don't want to miss any of them. They're all important. And finally, in our experience, we find some of our partners to begin to draw lines on issues like what you mentioned yourself, Alexa, bodily autonomy. The issue of bodily autonomy, the concept of bodily autonomy, which is so fundamental to the Beijing Declaration and the ICPD process and the SRHR agenda, is an area that many faith partners really struggle with. And we have to crack that. And so we need to address that proactively. Agency, the feminist agenda. The faith community needs to embrace these phenomena and really engage it well. And if we are to respond to the kind of movement that Emily was describing in Sweden, as a faith community, we need to have a narrative for our secular partners that is compelling in regards to how we are promoting women and girls' agency comprehensively.
Thank you, Dan. I'm especially noting the life cycle consideration and how reproductive health at any point in a person's life is significant. Would anyone else like to speak to it?
Yeah, can I say something?
Mhm.
Yeah, thank you very much. And I think when we are talking about the love, justice in reproductive health, yes, this is very important, but we should not forget this group which always is behind women and girls with disability. Whatever, when we are talking toward love, we need to remember them. We need to put the good policies and programs which will help them, and to create a big awareness to the community to understand the right of this group on their right to get the reproductive health services and to have a good environment to take care of them. But generally to give the education to the community and understand that these people really, they need also to have the right for the reproductive health.
Thank you, Dr. Martin.
Thank
You
you so
start.
much. Someone is okay. Thank you so much. First of all, for me, I look at the document, and this is something that is going to help us a lot, the churches, and is also going to change the perspective of the churches, because at some point we misquote the Bible also to justify violence, to justify denying access to sexual reproductive health services. So I think this is a good document. And without adding more, I think my colleague Dan has mentioned a lot. I just would like to add one thing under action within the churches. Beside the information sharing, I think also is good to include the aspect of providing those psychosocial support, especially for those who already experience issues of reproductive health. For example, even adolescents conceive and then they come to church, they should not be seen as something, like abominations. At least the church should be able to provide counseling for those adolescents. Then also, as Dan put it, it's good to put more emphasis also under the comprehensive sexuality education. Prevention is better than cure. The experience, I'm just looking at the comprehensive sexuality education that we have done. The school where we have targeted, there is no registered pregnancy now. There are no like this. It also reduced the issue of the bully, also the drug abuse. Also it also reduced this issue of media where you see things and you think they are reality, which I've seen it is covered there. But I think we need to expand a little bit on how the churches can scale out those activities. Otherwise, I think I provided some comments some time back and I've shared that. Thank you so much.
Thank you, Naikos, and raising up the issue of psychosocial support, not just, expanding it to psychosocial support. Emily, did you want to share?
Yeah, thank you. I think it's a wonderful document, and I think it shows up a lot of also diversity on how this issue has been related or approach, which is often something that has been quite hidden or forgotten. So I think that really is important to bring that for the forefront, because there has been larger historical diversity and currently on these issues than we sometimes hear in the kind of public debate. As I mentioned before, that this kind of polarization creates this image that these issues never meet, but we see that there is, of course they do, and people do with various languages that they use on the ground. You do this work and meet the needs of their communities. And I think this also maybe does a great work of trying to like translate it between worlds. I think Dave just mentioned there as well, there's a need for us to kind of find our own language and also translate and find, translate the work of faith communities to other agencies. And that's hugely important because often faith actors are not engaged in those spaces. So we need to unpack a lot of these things. And I think this is a great start. And it's really good that it also has both an evidence base, like what are we talking about? What is the impact and who is affected? That's a very important place to start. And then, of course, the specifics of what are we, how are our faith communities specifically responding to that? How does it relate to biblical principles and theology? And I think some of the things that I want to maybe highlight is that are mentioned in there, the encouragement to create safer spaces. I think there's something crucial in that. And I think also the encouragement to everybody and all of us, even we do that in our own work, is really think about what we mean by a safe space when we talk about that. How do we set that up, and who's centered, and how do we make that? Because sometimes these are not safe spaces. And I think we need to spend a lot more time on thinking about how we do that, not just thinking about centering the content of these conversations, but how we do this work. I also think that there is a lot of gifts in faith agencies to bring to these issues that we sometimes forget that we have. One thing that I really want to notice is also the notion of being a referral, especially if you're a health service. Good referral to other places is a very important act, and sometimes it's okay maybe not providing all the answers if you don't have them. It's also okay to refer to those that are comfortable and have that. And I think it's also crucial that it's linked to broader social justice issues. And I think this is a justice issue that's not new to us as faith communities, centering justice. And there's so many different moral theological angles for us to look at when we look at this as a justice issue. One thing I would like to add is really deep theological investment and looking at these things. We have some partners that are engaging in theological education that is contextual, critically engaging in their context on the intersection of gender, health, and religion. I think that this area just needs more development of contextual theology. I also think that there is a lot of misunderstandings in around rights language in relation to these things. And I think that's also a lot of misconceptions. While a lot of actors work with rights-based approaches in their work, that is about centering empowerment or participation, non-discrimination. And also I would add there that even there around comprehensive sexuality education, which is something that is often also there's a lot of misinformation and misconception around that. Well, if one look at the UNESCO definition, it very much can be contextually and culturally, altered, and people use different languages for these things. So I think this is all the concepts in there's helping to unpack some of these things, that there's a lot of misinformation about when it doesn't need to be. And can I say one last thing? I think that was good, because that's very much at the center of how Act Church of Sweden have journeyed on this issue, is also the acknowledgement when we have done harm as an institution. And that's an important part of an acknowledgement of that. That encourages, that says that we're, trustworthy also, that we acknowledge our own history, because we don't start from one point and end there. We are on a journey with these issues.
Thank you, Emily. Thank you, everybody, for reviewing and contributing, and also raising up gaps that you saw and what it will take. With our time left, we will now turn to the question and answer portion. As your questions are coming in, we will field them and ask our panelists to speak to them. Before we do that, I just want to say one note about the World Council of Churches, which the World Council of Churches is a fellowship of over 350 member churches. And so within that, there's a wide range of approaches to these issues. But the goal that we want to raise here is to think together about what it means to alleviate the suffering that people experience within reproductive health. And like Emily said, what does it look like to acknowledge the ways that our churches and faith communities themselves have stood in the way of alleviating that suffering. And so we already have a lot of questions coming in. There are a couple that kind of speak to the same thing. There's a lot of questions asking, what can we do? What can churches do? So if you all could say, the framework has some of this, and you all spoke to that a little bit, but if you all could share about what sort of immediate concerns or challenges you see with faith communities, what is like an immediate next step? That would be great. And obviously this is big because faith communities range, but in your experience, what do you see as the biggest next step?
Alexa, not necessarily prepared for this question, but because we have had such a rich and promising experience when we proactively engage with faith partners on issues like this, and we invest and take the time qualitatively to work through issues, we see we see great success, we see change, and we see hearts opening and attitudes changing. And so, in a general way, I think that my recommendation would be for as much dynamic engagement with faith partners and qualitative engagement as possible, because it's only when we take the time to delve deeply into the issues and attitudes and understandings that we see the change. The change in our experience doesn't happen very well with a kind of top-down approach or just documenting recommendations. And that's interesting reading, but it takes dynamic engagement and deep engagement really to see change. Because again, it's a social and behavioral investment. It takes time to engender that. And so the more partners can do that with faith actors, the greater our success will be, I think. It doesn't happen on its own.
Alexa, I didn't get the questions.
Yeah, I guess one, if you're someone who is engaged in a faith community and want to get started on engaging reproductive health from a perspective of our faith, what is the immediate next step?
Thank you so much. This is not something that happened in a day. It requires more consultations, and knowing that the community that we serve, they are not only Christians, so they're not churches. So it involves a range of different actors where you bring all different faith actors together to discuss on the issues of sexual reproductive health. You first need to change the behaviors within before you move out to the community. Otherwise, it can be very hard. You can speak this language, and then your colleague also use the same different language. It can be very hard. So just a scenario in South Sudan, when we started the comprehensive sexuality education, there was a lot of blockage because of the norm, cultural norm, religious norm, and the way they see the word sex. They thought maybe you are telling people to have sex, so to use this language, but in actual sense, you are trying to provide information on how this person can make a decision that will not affect their health, their sexual reproductive health. So when we brought these people together, in the first place, they will push out the way. You continue the next meeting, you tell them, okay, you read and understand the next time. So until they accept, we also engage the communities. You have to engage the government. You also engage different faith actors. So when everyone come to common understanding, this is when you start in the community or in a school. And we have seen the result where the same people who were pushing us away coming back and say, oh, we never understood it was like this, you know? So it is a long process, but it can yield good outcome. The only thing that we also need to do as the churches, when we go to community, we need to use the language that the community understand, the practices, so that they adopt the knowledge, so that it doesn't seem like it's something foreign. In the areas of family planning, for example, in South Sudan, the community actually practice family planning in actual reality because they abstain. For example, if you give us, you will not meet your husband or wife for 3 years at the community level before you come together. Now, what do? We say, okay, this is a good practice, but in case you want to stay together with your wife, these are the contraceptive you can use, because the aim was toward one thing, to prevent pregnancy or to prevent disease. Because sometimes the man goes out, they leave their wife at home, they go and sleep with others, and then they bring in disease. So they have to play around, use the good practice, build on it to add what the community can digest, and you will see the change slowly. So it is start with us at the churches before we move out. Thank you. I saw a question, I don't know if I can address, about the access to health services in the QAs. Is it okay? Yeah, your questions about this is a human right and what is the government is doing to ensure those in the remote area access health. South Sudan is very unique and it has been in a long crisis. And the current government that we have is divided into different political aspects where some parties cannot move to the area A of the other parties, but they try their best to come up with toolkits on how the health structure is supposed to be, though they could not implement in practice. So in those remote areas, the only access is through NGOs. Like there was a very deep area where we went to distribute medical equipment. It was World Vision providing services in those areas. The government could not even go there to access the area. MSF, but they have that in mind, but they could not do it, maybe because of capacity or whatever reason. You have health workers who have not got their salary for 1 year or two. So it is not something that is easy. The only thing we do is to provide information on how to have maybe healthy pregnancy, because there is no way you can access. But those who have access are mostly people who live in town, where there are private clinics. That is the situation. So maybe with time, things will change, but this is the context we are in. Thank you.
Alexa, if I may quickly, before I'll have to drop off in a moment, there are a couple of questions that participants have raised in relation to mental health and sexual and reproductive health and women's rights. And I want to affirm those questions. I think they're very important. And I think that the faith community does play a very important role in addressing psychosocial issues amongst their communities. World Vision has worked with nearly 200,000 faith actors in psychosocial and psychological first aid training to help enable them with those engagements. We see an increasing evidence base linking mental health and maternal and child health and nutrition outcomes. So it's quite clear that this is an important and increasing issue to deal with. And at a universal level, is an issue that can be addressed by lay health workers, amongst whom we might include faith actors at community level. So this is a very important issue, and its address is attainable by our faith partners who can play a very instrumental role in it. So I appreciate those points. And I would like to encourage everybody that there is very important work that can be done in that area and with faith partners.
Alexa, I can respond to the kind of first step question. If you can hear me okay. Yeah. I think that really also always depends on where one is at as an actor working, or like what is the work that is already kind of happening either in the public arena or pastorally or in services. So I think it's starting from where one is at is if it's health services already doing that work most likely, but also then seeing who are we missing, and how is that work serving our communities, which is of course people thinking about all the time. There's always a need for advocating for justice around these things in the public arena. and of course being in the public arena of communities. We are duty bearers. That's something that is very important to moral duty bearers, or sometimes real duty bearers. So there's a responsibility there. And I think just if it's very new, an immediate next step is always like, just read this document. It's with all the references that is in that, it also shows there's a lot more to read on this. Like, how do we take this knowledge and kind of explore how does that sit with us and the work that we do? There's resources there and a lot of diverse perspectives from many parts of the world in relation to these intersections. And in there, very much like, how do we stay open with this? To not come in with a firm perspective, this is how we think about this, but explore. And I think that can really be about starting and centering those that are affected, those of us that when we meet communities, not to come have the answers, but actually centering those that are affected. And I think that's also an intervention that is mentioned in the document, but contextual Bible reading is a very important tool for that. And then it is about, like, is it a public perspective or a pastoral perspective that we can take on these matters? Yeah.
Thank you, Emily.
Can I say something before it's over?
Yes, and then we will close it off.
Okay, thank you so much. I just wanted to add that even in the areas where there is no health facilities, no school, you will find churches. That means the churches, the faith actors have access to the community to share information. The faith actors are more trusted, so they can advocate for the government to provide those services to the community. Thank you.
Thank you, Naikoas. Yes, World Council of Churches is made up of faith communities. And again, I just want to thank each of you so much for your time. I know some people had to duck out early, but I really appreciate your time reviewing the framework and speaking to it. And the framework will be available online. We have a QR code which you can scan if you would like to access it right now. And I just want to reiterate what was said about the need for dynamic partnerships, the need for understanding how this issue impacts all people from all different kind of marginalized identities, and the uplift, the power that churches as places of transformation, as places of healing, the power that churches have to address this issue. And so again, I want to just thank all of our panelists. I'm going to clap here in my room by myself, but hopefully you can hear the applause. And also I wanted to thank Walter, our communications person at the WCC, for helping us facilitate this webinar. And I also want to thank you, the participants, for joining us for this conversation. If you want to keep engaging with the WCC and our partners about this work, you can email us at healthandhealing@wcc-coe.org. We can put that in the chat right now if you want to stay in touch with this work, because as Gracia said, you are important. We need your help in implementing this framework. And so if you want to reach out to us, that would be great. I'll put the email in the chat right here. But with that, thank you all so much. I hope you have a wonderful rest of your day. We are at time, so that is all we have. Go ahead and download the framework, and hopefully we will cross paths again soon. Thank you.